Welcome to the deep dive. Today we're jumping into a really practical set of notes. Think of it like a high-speed download on core nursing and pharmacology concepts. We're talking the key points you need to get, how the body works, what happens when things, go sideways, like in shock, and importantly, what some of these essential meds really do.
That's right. And our mission here really is to help you pull out the most important nuggets quickly. We want to connect these concepts so you can see the bigger picture, understand not just what things are, but critically, why they matter. Especially in those high-stakes situations, it's kind of a shortcut maybe to feeling well-informed on these foundational topics.
Yeah, and we've got some pretty interesting points to dig into, like what actually happens when the body hits fight or flight, how drugs tap into that system. There's this specific type of shock that's a bit weird. We'll talk about that, why some fluids are absolutely treated like drugs, and some surprising effects of common medications you might run into.
Exactly. And understanding these core ideas is just crucial. Whether you're a student, maybe refreshing your knowledge, or honestly just curious about how critical care works, we'll really try to pinpoint those details that can give you those, aha moments. See the clinical relevance.
Okay, let's unpack this first bit then, starting with the basics. The body's control systems, the nervous system, specifically the sympathetic and the parasympathetic systems, where are these located? Central nervous system, peripheral.
Good question. They're key parts of the peripheral nervous system, so outside the brain and spinal cord mostly. And they operate largely, automatically, controlling heart rate, digestion, breathing, that sort of thing.
Right. And the sympathetic system, that's the famous fight or flight, isn't it? What kind of symptoms pop up when that gets activated?
Absolutely. Just think about what your body does under stress. Heart races, right? Pupils get wider. Airways open up, trying to get more oxygen in. Blood gets shunted away from, say, digestion and pushed towards your muscles. It's prepping you to, fight or run like heck.
Okay, now here's where it gets really interesting for us drugs. They can tap into this whole system. We see terms like adrenergic drugs and cholinergic drugs. So an adrenergic drug, does that generally stimulate the sympathetic side or the parasympathetic?
Adrenergic stimulates the sympathetic nervous system.
Yeah.
The name kind of give it away. Think adrenaline, epinephrine. That's your classic adrenergic chemical. Cholinergic drugs, on the other hand, they work on the parasympathetic system. That's the rest and digest side.
Okay, so based on that, let's think about some examples from the notes, like albuterol used for breathing, or dobutamine for the heart. Pressors like norepinephrine, dopamine, are these generally going to be adrenergic or cholinergic?
Well, albuterol hits receptors in the lungs, opens the airways. That sounds like a sympathetic effect, right? Preparing for action. Dobutamine, norepinephrine, dopamine, they're often used to support circulation, increase heart rate, squeeze blood vessels. Definitely sympathetic effects. So yes, all those are adrenergic. Now, what about atropine? That's another one mentioned.
Atropine. I know it's used if someone's heart rate is really slow. So if the parasympathetic slows the heart and atropine speeds it up.
Exactly. You got it. Atropine blocks the action of acetylcholine, which is the main messenger for the parasympathetic system. So it's an anticholinergic. It inhibits those rest and digest signals, basically letting the sympathetic side have more influence and increase the heart rate.
Right. Okay. Let's stick with those anticholinergic effects for a sec. There's that classic rhyme that helps you remember the side effects.
Oh, yeah. It's super memorable. Can't see, can't pee, can't spit, can't poop. It really nails the common side effects. Blurred vision, difficulty urinating, dry mouth, and constipation. And thinking about vital signs, if you're blocking the system that slows things down, you'd expect the heart rate to go up, right?
Makes sense. So thinking clinically, when would giving an anticholinergic generally be a good thing? What condition?
Well, it's good when you want to counteract those rest and digest effects. So like you said, if someone has a really slow heart rate, bradycardia, blocking the parasympathetic slowing, can help speed it up. Or maybe someone has an overactive bladder with spasms, an anticholinergic could help relax that muscle.
And when would it potentially be a bad idea?
You definitely be cautious or avoid them if the side effects could worsen an existing condition. Like someone with glaucoma, the pupil dilation can increase eye pressure, which is bad. Or, say, someone with a bowel obstruction, slowing down the gut even more is obviously dangerous there.
Okay. The notes bring up dicyclamine specifically. What is that one? What's it for? How's it work?
Dicyclamine, that's an anticholinergic, and it's specifically used quite a bit for irritable bowel syndrome, IBS. It works by relaxing those smooth muscles in the gut, which helps cut down on the cramping and spasms you get with IBS. It's technically an antimuscarinic, which is just a type of anticholinergic.
Gotcha. And how about benzotropine? That rings a bell for neurology use, right? What class is it and what side effects would you expect?
Benztropine is another anticholinergic, yeah, often used to manage movement disorders, things like Parkinson's symptoms, or maybe side effects from some antipsychotic meds. And knowing it's anticholinergic, you can predict the side effects, right? Dry mouth, blurry vision, constipation, maybe trouble peeing, faster heart rate, the usual suspects.
What happens if someone gets way too much anticholinergic medication, like anticholinergic toxicity?
Right, so if you got too much anticholinergic effect, you need to boost the opposite system, the cholinergic one. So you give a drug that increases acetylcholine activity. Often, these are anticholinesterase inhibitors, drugs that stop the enzyme that normally breaks down acetylcholine.
And the notes point out there's a common ending for some of those antidote drugs.
Yeah, you often see names ending in stigmin, like physostigmine or neostigmine. They boost acetylcholine by blocking its breakdown enzyme.
Quick flip side cholinergic crises, is that from too much or too little of those choletigmine type drugs? And what's the antidote then?
Cholinergic crisis is from too much anticholinesterase drug. Way too much acetylcholine activity. And the antidote. Interestingly, it's atropine, an anticholinergic. You're using it to block that overwhelming flood of acetylcholine. It's like slamming on the brakes atropine when the gas pedal acetylcholine is stuck to the floor.
Okay, let's switch back to the adrenergic side. Stimulation again. If you stimulate beta-1 receptors specifically, what's the expected effect?
Beta-1 receptors think primarily heart. Stimulating them increases both the heart rate and the force of the heart's contraction. The squeeze gets stronger. Think beta-1, you have one heart.
Okay. The notes mention pseudoephedrine as an alpha-1 adrenergic agonist. That's in a lot of cold meds. So based on it being alpha-1, what side effects might you anticipate?
Right, so alpha-1 receptors are mainly in the smooth muscle of blood vessels. They cause vasoconstriction tightening of those vessels. That's why pseudoephedrine works for a stuffy nose. It shrinks the swollen blood vessels there. But because it constricts vessels elsewhere too, you can see side effects like increased blood pressure and maybe some restlessness or jitteriness because you are kicking in that sympathetic response a bit.
And norepinephrine, another powerful adrenergic agonist we mentioned. Why is that one used? What do we want it to do? And what's super critical to monitor?
Norepinephrine is a big gun used in severe low blood pressure situations, especially certain types of shock, like septic shock. We want it to powerfully constrict blood vessels. That's mostly its alpha-1 effect to bring that blood pressure way up and perfuse vital organs. It also has some beta-1 effects, boosting heart rate and contractility a bit. Because it's such a potent vasoconstrictor, you absolutely have to monitor blood pressure continuously, heart rate rhythm too. And really importantly, watch for signs that maybe blood flow to the fingers and toes is getting clamped down too much. Check skin color, temperature, pulses.
Okay. The term inotropic comes up in the notes. What exactly does that mean? And what do positive inotropic drugs increase? What about beta blockers? Are they inotropic?
Inotropic refers specifically to the force of muscular contraction. When we talk about drugs, we usually mean the heart muscle. So a positive inotropic drug increases the force of the heart squeeze. It increases contractility. Now, beta blockers, like atenolol or metoprolol, they slow the heart rate. Are they inotropic?
Well, they affect the heart's action. Maybe they decrease the force.
Exactly. They are inotropic, but in the opposite direction. Beta blockers are negative inotropes. They decrease the force of contraction, along with decreasing the heart rate. So positive inotropes make the heart squeeze harder. Negative inotropes make it squeeze less hard.
Okay, good distinction. Let's shift from the nervous system control now to the circulatory system and fluids. This is obviously critical for understanding shock and emergencies. First off, just a baseline, what's considered a normal hemoglobin level.
Right, hemoglobin. Normal range is roughly 12 to 18 grams per deciliter. It varies a bit between men and women, but that's the ballpark. It tells you about oxygen carrying capacity.
And IV fluids. Let's review some basics. Which common fluids are considered isotonic? What about plasmolite? And D5W specifically when it's still in the bag.
Okay, isotonic solutions. They have about the same concentration of stuff as our blood plasma. So when you give them, the fluid tends to stay in the blood vessels, expanding volume there. Classic examples are normal saline, 0.9% sodium chloride and lactated ringers, or LR. Plasmolite is also an isotonic crystalloid. Now, D5W, that's 5% dextrose in water. It is isotonic when it's just sitting in the IV bag. But once it goes into the body, the cells gobble up that dextrose really fast, leaving behind mostly just water. So in the body, it acts more like a hypotonic solution.
Interesting. And this connects to a really powerful phrase highlighted in the notes. Fluid is a drug when treating hypovolemia.
Yeah, that phrasing really sticks, doesn't it? It emphasizes that giving IV fluids, especially when someone's volume is low hypovolemic, it isn't just like giving someone a drink of water. It's an active medical treatment. It has indications, contraindications, potential benefits, potential risks, just like any medication. You need the right fluid, right amount, right rate, and you have to monitor the effects.
Absolutely. And speaking of fluids for hypovolemia, the notes mention colloids. What are those? How do they work? And you need to use the word oncotic.
Okay, colloids. These are IV fluids that contain big molecules, like proteins or starches, that are too large to easily slip out of the capillaries. Think albumin or some synthetic ones like hetastarch. How they work is by increasing the oncotic pressure inside the blood vessels. Oncotic pressure is like the pulling power exerted by these large molecules. So, by boosting that oncotic pressure, colloids effectively suck fluid from the interstitial space, the space between cells, into the blood vessels. They pull volume into the circulation. So you might need less volume compared to crystalloids to achieve the same effect.
Got it. Albumin is specifically mentioned for hypovolemia. But the notes bring up an interesting point about who might not receive it.
Right. This can depend a bit on context and goals of care. Because giving albumin is an active intervention to support circulation, sometimes in situations where the overall goal is comfort care, or if a patient has specific directives like a do not resuscitate order. Giving aggressive volume expanders like albumin might not align with those goals. It requires careful consideration of the individual patient's situation and care plan.
Okay. And what's a major potential complication of giving albumin? What signs would you watch for?
Because it's so effective at pulling fluid into the blood vessels, the big risk is fluid overload, hypervolemia. You're essentially overfilling the circulatory system. You'd watch really closely for signs like crackles when listening to the lungs, shortness of breath, maybe difficulty breathing, possibly even swelling, like peripheral edema.
Makes sense. This leads us right into shock, that critical state where the body's circulation just isn't meeting the tissue's needs. What are the sort of general signs and symptoms of shock, and what are the absolute first priorities in managing it?
Yeah, the classic signs, generally speaking, include low blood pressure, a fast heart rate, the body trying to compensate decreased urine output because the kidneys aren't getting enough flow. Often, cool, clammy skin, though there's a key exception we'll get to, and altered mental status like confusion or lethargy. And the first priorities, the notes nail it, ABCs. Secure the airway, ensure adequate breathing, support circulation. You're constantly monitoring vitals, giving fluids, maybe meds, depending on the cause.
Okay. And if someone in shock is starting to turn the corner, getting better, what vital sign changes would you expect to see?
You'd hope to see the opposite trend, basically. Blood pressure starting to come up, heart rate starting to come down towards normal, urine output picking up, and importantly, their mental status should start clearing up.
Great. Now let's get into some specific types of shock mentioned. First, hypovolemic shock. Why does this one happen? Is it not enough volume, or is it massive vasodilation?
Hypovolemic is all about volume loss. Not enough fluid or blood in the pipes. Could be from hemorrhage, bleeding, or severe dehydration from vomiting, diarrhea, burns, whatever. The container, the blood vessels, are okay structurally, but they just aren't full enough to maintain pressure and flow.
So if it's from hemorrhage, actual bleeding, what specific blood product is most crucial to give? PRBCs, cryoprecipitates, platelets.
If they're actively bleeding and losing blood volume, the priority is replacing that oxygen carrying capacity.
Yeah.
So packed red blood cells, PRBCs, are essential. You might give other things like cryoprecipitate if there are specific clotting factor issues, or platelets if the count is dangerously low, especially with massive transfusion, but the core replacement for lost blood is PRBCs.
Okay. Now, cardiogenic shock. This one's different, right? Do these patients typically need lots of fluid? What could happen if you just pour fluid into them? Can inotropic drugs help here?
Right. Crucial difference. Cardiogenic shock isn't a volume problem. It's a pump problem. The heart itself isn't pumping effectively, maybe after a big heart attack. Giving these patients large amounts of fluid can be really bad. It can overload the failing heart, back fluid up into the lungs, cause pulmonary edema, make breathing much worse. So fluids are given very cautiously, if at all. The focus isn't volume. And yes, positive inotropic drugs can definitely help here because they make the failing heart muscle squeeze harder, trying to improve output.
Gotcha. Then there's neurogenic shock. The notes say this one is a bit weird, wasn't covered elsewhere. Who gets it? What's strange about its presentation compared to other shocks? Like, what does the BP do? The pulse. And their skin cold and clammy or warm and flushed. Vasoconstriction or dilation.
Neurogenic shock, yeah, it's distinct. You typically see it after high spinal cord injury, like in the neck or upper back. What's really weird is the heart rate. Most shock types cause a fast heart rate, right? Tachycardia. But a neurogenic shock because the sympathetic signals from the brain are cut off below the injury. You often see a slow heart rate, bradycardia, or maybe just normal, but the blood pressure is very low. And that low BP is due to massive vasodilation. The blood vessels below the injury lose their sympathetic tone and just relax completely. Because of that widespread vasodilation, instead of being cold and clammy, the skin below the level of injury is usually warm and flushed. So low BP, lower normal HR, warm skin, that's the classic triad for neurogenic shock.
That warm skin is definitely a key point to remember. Okay, speaking of managing low BP, we talked about powerful vasopressors like norepinephrine. Should these drugs be stopped suddenly or weaned off gradually, and why?
Oh, absolutely. 100% gradually. Always. These drugs are artificially squeezing the blood vessels hard to keep the pressure up. If you just stop them cold turkey, that support vanishes instantly. The vessels relax, and the blood pressure can absolutely crash. You can get circulatory collapse. You have to taper them off slowly, carefully watching to see if the patient's own body can take over and maintain pressure.
Right, critical point. Let's quickly touch on anaphylaxis. It's that severe allergic reaction can lead to anaphylactic shock. What are the key signs, and maybe more importantly, which signs tell you this needs epinephrine now, not just, say, an antihistamine?
Yeah, anaphylaxis signs can include hives, itching, swelling, especially concerning if it's the face, lips, tongue, or throat. Difficulty breathing, wheezing, maybe a change in their voice. Also nausea, vomiting, dizziness, and that drop in blood pressure. Now the critical signs, the ones that scream epinephrine needed, are anything involving the airway trouble breathing, throat swelling, wheezing, stridor, or the circulation dizziness, feeling faint, low blood pressure. Antihistamines might help with the skin stuff, but they won't stop the life-threatening airway or circulatory collapse. That's what epinephrine is for.
And the simplest but maybe most effective advice for someone with known dangerous allergies, according to the notes.
Avoid the allergen. Sounds obvious, but strict avoidance is the absolute cornerstone of prevention.
Okay, let's shift gears again. Looking at some other specific medications and conditions covered in these notes, starting with seizures, what are some of the general classes of drugs used to manage seizure disorders?
The notes list quite a few. There are benzodiazepines, like diazepam or lorazepam, barbiturates, like phenobarbital, though used less often now, hydantoins, like phenytoin, succinimides, like ethosuximide, and several others. They all work in slightly different ways within the brain to try and calm down that excessive abnormal electrical firing that causes a seizure.
Okay, so if someone is in the hospital, maybe on the floor, and they suddenly start having a seizure right there, what's the likely first medication the doctor would order?
For an acute ongoing seizure, the immediate go-to is usually an intravenous and IV benzodiazepine. So IV lorazepam, maybe 5E diazepam. They work really fast to stop the seizure activity.
And how do those benzodiazepines actually work to stop the seizure? The notes give a hint. Remember GABA?
Ah, yes, GABA. GABA is the brain's main inhibitory neurotransmitter. It's like the brain's natural brake pedal. Benzodiazepines basically make GABA work better. They enhance its effects. So by boosting that stop signal, they make the neurons less likely to fire uncontrollably, helping to shut down the seizure.
Okay. How about succinimides, like ethosuximide? Often used for absence seizures, right? The notes say they delay something influx into something and ask if they work on GABA.
Right. Succinimides work differently. Their main mechanism is thought to be blocking or delaying the influx of calcium ions into certain neurons, particularly in a part of the brain called the thalamus. This seems to be important for interrupting absent seizures. And no, they don't really work directly on the GABA system like benzodiazepines do. Different target.
Side effects are always a big consideration with anti-seizure meds. The notes specifically flag that drugs like barbiturates and benzodiazepines make it unsafe to drive. Why is that?
Yeah, that's a really important safety point. It's because they are central nervous system depressants. They can cause significant drowsiness, sedation, dizziness, impaired coordination, slowed reaction time, basically all the things that make operating heavy machinery, especially a car, extremely dangerous.
Makes sense. And why do some people end up needing 2 or even 3 different anti-seizure medications while others might do fine on just one?
Well, seizure disorders can be really tricky to control sometimes. One drug, even at the highest dose someone can tolerate without bad side effects, might not be enough to stop all the seizures. So doctors might combine drugs from different classes that work through different mechanisms. The idea is that attacking the seizure activity from multiple angles might get better control. Plus, sometimes using lower doses of two drugs together can actually lead to fewer side effects than using a really high dose of just one drug. It's about finding that balance.
We mentioned vidazepam for acute seizures. What are its main side effects? Any really serious, life-threatening ones to watch for?
Common side effects, sure, drowsiness, dizziness, maybe some unsteadiness. But the big one, the potentially life-threatening one, especially if you give it IV too fast, is respiratory depression. It can slow or even stop breathing. So you have to monitor their breathing, their oxygen saturation really, really closely when giving IV benzos.
Okay, switching conditions now to Parkinson's disease medications. The notes mention levodopa-carbidopa, a really common one. If a patient on this starts getting that on-off phenomenon, where their symptom control suddenly fluctuates a lot, what might the doctor do to help, based on the notes?
Yeah, that on-off thing can be really frustrating for patients. The notes suggest a few strategies the provider might try. They could adjust the timing of the doses, maybe give smaller doses more frequently, or they might change the formulation, or even add another type of Parkinson's medication to help smooth out those peaks and valleys and keep the levodopa working more consistently.
How about entacapone, another PD drug? How does that one work? What does it inhibit?
Entacapone is what's called a COMT inhibitor. COMT stands for catecholomethyltransferase. It's an enzyme in the body that actually breaks down levodopa before it gets to the brain. So by inhibiting COMT, entacapone basically protects the levodopa, allowing more of it to reach the brain where it can be converted to dopamine, which is what's needed to help with Parkinson's symptoms.
Okay. And donepezil. What's its action? Does it increase or decrease acetylcholine? And who typically takes this medication?
Donepezil is an acetylcholinesterase inhibitor. So it blocks the enzyme, acetylcholinesterase, that normally breaks down acetylcholine. By blocking that breakdown, it effectively increases the levels of acetylcholine available in the brain. It's primarily prescribed for patients with Alzheimer's disease, usually in the mild to moderate stages. The idea is that boosting acetylcholine can help with cognitive function and memory, at least for a time.
Let's quickly run through a few other specific drugs mentioned here. First, methacarbamol. What is it? Drug class? How can it be given? Is it over the counter? And what side effects would you expect?
Methacarbamol is a muscle relaxant, central-acting muscle relaxant, used for acute painful muscle spasms like from an injury. It can be given orally as tablets or sometimes intravenously. No, it's not over the counter. It requires a prescription. And since it works on the central nervous system to relax muscles, you'd expect side effects like drowsiness, dizziness, lightheadedness, similar to other CNS depressants.
What class is cyclobenzaprine?
Cyclobenzaprine is also a commonly used muscle relaxant, often prescribed for acute muscle spasms. It's actually structurally related to some older antidepressant medications, the tricyclics.
Okay. And lastly here, rocuronium. What kind of drug is that? What does it do? And importantly, will it control pain? Will it sedate the patient?
Rocuronium is a neuromuscular blocking agent. It's a paralytic. It works by blocking the signals from nerves to muscles, causing temporary muscle paralysis. It's used in settings like surgery or the ICU, often to make it easier to insert a breathing tube or to keep someone completely still while on a ventilator. And this is absolutely critical. Rocuronium provides zero pain relief and zero sedation. The patient is paralyzed, but they can still feel everything and are fully conscious unless you also give them separate medications for pain and sedation.
That's a crucial point, and it leads right into something else highlighted in the notes about prioritizing patient care. For drugs like rocuronium, and also when reversing a benzodiazepine overdose, the notes ask, do we monitor the machine first or the patient first?
Yes, this is such a fundamental principle, and the answer is always the patient first.
Yeah.
With rocuronium, like you said, the ventilator machine might be showing perfect numbers, good oxygen levels, nice pressures, but if the patient wasn't adequately sedated first, they could be paralyzed, unable to move or breathe, but completely awake and terrified. You have to assess the patient, their consciousness, signs of distress. Are they comfortable?
Exactly. The machine data is important, but it doesn't tell the whole story.
Right. Same idea if you're giving flumazenil to reverse a benzo overdose. The pulse oximeter might show their oxygen saturation coming up, which is good data. But you need to look at the patient. Are they actually waking up? Are they breathing effectively on their own now? Can they protect their own airway? The patient's clinical status is the primary focus. The machines just provide supporting data.
Very well put. Okay, briefly, the notes just touch on a few herbs. What are the claimed effects people are usually hoping for when they take, say, ginkgo biloba, echinacea, ginger, capsaicin?
Right, just quickly, ginkgo biloba is often taken with the hope of improving memory or circulation. Echinacea is commonly used, thinking it might boost the immune system, maybe fight off colds. Ginger is very well known for helping with nausea and motion sickness. And capsaicin, usually used topically in creams, is for pain relief, like for arthritis or nerve pain.
Okay. Just a couple more quick-fire specifics from the notes. Alcohol and benzodiazepines compatible, yes or no?
Absolutely, unequivocally NO, huge danger. Both depress the central nervous system. Combining them dramatically increases the risk of severe respiratory depression, coma, even death. Never mix them.
Okay. If dopamine, that powerful vasopressor, extravasates, leaks out of the vein into the surrounding tissue, what do you inject into that area to counteract it?
You inject phentolamine. It's an alpha adrenergic blocker. Dopamine causes intense vasoconstriction. If it leaks out, it can damage the tissue by cutting off blood flow. Phentolamine locally blocks that alpha effect, causing vasodilation, hopefully restoring blood flow to the area and minimizing tissue injury.
Got it. And finally, the specific reversal agent for a benzodiazepine overdose.
That would be flumazenil.
Wow. Okay, that really was a deep dive. We covered quite a bit of ground there. Everything from the body's fight or flight response, how drugs mess with that, different types of shock, which is always critical, key points about fluids, seizure meds, Parkinson's drugs, and those really specific but important details about interactions and antidotes, all pulled from these review notes.
Yeah, hopefully walking through this material, connecting some of those dots, has helped clarify these essential concepts for you. Understanding how these systems work, how the meds interact, it's foundational for understanding care in so many different situations.
Right. We really tried to pull out the details and the questions that were highlighted in the source material, hoping to give you those focused insights.
Absolutely. And maybe let's leave you with this final thought to chew on. We talked a lot about monitoring the patient first versus just looking at the machine, especially with things like paralytics or reversing an overdose. How does that core principle, prioritizing direct human assessment over just the numbers on a screen, how does that apply more broadly? Across all the critical concepts we touched on today, from spotting those subtle signs that shock might be improving to anticipating potential drug side effects based on how you know they work. What does focusing on the patient first truly tell us about the art and the science of providing really good care?
Definitely something to think about as you continue to learn and connect all these vital pieces. Thanks so much for diving deep with us today.